So if you've been told you need a knee replacement or you've got severe knee osteoarthritis, don't worry, I'm going to talk to you about what that means and also why there's still a really good chance you may not need knee replacement surgery, and there's other treatments combined can keep you away from surgery. I'm going to tell you about some patients of mine who've come to see me. They've been told they have severe osteoarthritis in their knees, that their only option is knee replacement surgery. I'm an orthopedic knee surgeon and I perform knee replacement surgeries most weeks. But 9 out of 10 patients that have seen me in the last decade have not needed full knee replacement surgery. And most of these patients are back doing all the things they want to be doing. So in this video, I'm going to be telling you why you are not your scans, what osteoarthritis of the knee actually means and how you will know whether you have it or not, why you don't always need total knee replacement surgery, but why if you do need it, you don't need to worry about it too much, because chances are it's going to go really, really well and you'll be glad you had it. But we're going to try to keep you away if possible. My name is Dr. Imbuldeniya. I'm an orthopedic knee and hip surgeon. I have a private practice in London and an NHS practice in London too. I've treated thousands of patients over the last decade as a consultant. Most of them I try and keep away from surgery. In particular, as I've grown and become more knowledgeable and more experienced, I try and treat patients with a holistic approach that I call OrthoLongevity. It's a biology first, surgery last approach where we treat you as an individual using the best aspects of lifestyle medicine, longevity medicine, physiotherapy, osteopathy, sports medicine. We optimize your metabolic health, your nutrition, look into your sleep, your stress. All of these factors together tend to either keep you away from surgery, or if you need surgery, your chances of doing well are significantly improved because all the other measures that we've taken to improve things. For those of you that have watched some of my videos, you'll know that I've changed really because of my own personal circumstances. I'm going to be 50 next year. I've got 4 children, 2 of which are really young. One's going to be 3 next week and the other one's 6 months old. I've also got 2 teenagers, the eldest of which may be going to university in September. So I need to be around. My own father died when he was 50, so that's had a big impact on me. My grandfather also died only age 42. So I need to be here, and I'm really into now trying to be healthy, be fit and active as strong as possible. I need to be playing with these children and running around when I'm in my 60s. So everything I talk to you about is everything that I've researched and learned about. But also, these are things that I practice myself, so I practice what I preach. And like other types of clinicians though, I am able to help you, along with my team, with aspects like nutrition, exercise, strength training, physiotherapy, injection therapy, but also as a surgeon can perform the surgery and we can offer advice and education on which types of surgery you might want to have and how you might want to speak to your own doctor and what questions you might want to ask your surgeon. So just before we move forward though, standard medical disclaimer that this is medical education. It's not personalized medical advice. Unfortunately, I'm not your doctor at present, but what I want to do with these videos is give you some idea about the topics that can sound quite intimidating and complex and arm you with knowledge, so when you see your medical practitioner or your clinical practitioner, you can talk to them on a more even footing about what your options are and any other treatments or options that they maybe haven't quite thought of, so you can make sure you're getting the best possible personalized treatment with the current best research evidence, so you have the best chance of doing really well and getting back to things pain-free as fast as possible with an early diagnosis and with the least invasive option possible. So ideally, if you can avoid a total knee replacement, you might have a partial knee replacement. If you think you need a partial knee replacement, you might have much smaller surgery like keyhole surgery or surgery to repair or replace or regrow cartilage. If you think you need one of those small operations, you might be able to do well with injection therapy like high-dose PRP or hyaluronic acid or Arthrosamid or corticosteroid. And if you think you need injection therapy, you maybe don't need those and you can do well with weight loss, strength training, sleep optimization, getting your vitamin D up, getting your blood sugars down, and all the other biological and metabolic optimizations we can do. So the idea is whatever treatment you think you're going to need or you've been told, maybe we can dial it back so you have the least or less invasive option. So I talked about a patient I only saw this week. She's a reasonably active yoga teacher, probably a little bit overweight in her own words, and that's really just natural because she's perimenopausal, has had 2 children, has been quite a busy lady looking after her family, and also she has a career. Alongside her yoga teaching, she does like to be active, and she's been getting quite bad pain around the front of her knee, worse when she goes up and down stairs. And she was told by a colleague that she has osteoarthritis in the knee and will need a knee replacement and probably has to give up yoga teaching. So patients commonly see me for second or third opinions. I actually had a lady a few weeks ago, I think I was her 10th opinion about her hip. So patients quite rightly now do want to seek multiple opinions from their doctors or surgeons, and I totally understand that and support that. It's the sort of thing I would do if I needed to make a big decision and I was consulting some sort of professional where I wasn't an expert. I'd want to maybe get different opinions. The problem is sometimes it can be confusing if we don't all think the same, and certainly with orthopedic surgeons or medical specialists, we don't all practice the same, and that's based on our own different experiences, our different training. Sometimes it's about the generation we're in and what we learned at the time. Sometimes it's about whether we're still willing to keep learning and innovating and knowing what's best. And sometimes it's just based on our own beliefs and values. So when I met her, I examined her, and then we organised some scans, and I felt very much like it didn't sound like she had full arthritis in the entire knee, but mainly that the front part of her knee, where her kneecap bone kind of rubs on the end of her thigh bone or femur bone. I thought maybe she was getting pain there. And actually she did have some cartilage in the area, was a bit thinner and a bit cracked, a little bit inflamed, a little bit sort of damaged, I guess, and roughened. So that will often cause clicking and crunching at the front of the knee, pressure if you wear high heels, also discomfort if you kneel, for instance, if you're trying to do gardening or get down on the floor playing with young kids, difficulty getting out of a chair, and often difficulty going up or down stairs or up or down inclines. So that's what it felt like when we got her MRI scans and x-rays. We could see that that was the case. She didn't have full-on osteoarthritis. Osteoarthritis of the knee means that the 3 main areas of your knee don't have much cartilage because it's all worn away, that the knee bones have bony spurs on them because of the arthritis, so the knee can get a bit more knobbly, for want of a better word. The knee sometimes isn't very straight. It can become bow-legged or knock-kneed, which we call varus or valgus. That's the medical terminology for that. Some knees with osteoarthritis are really stiff. They don't fully straighten in particular. That's called fixed flexion, or they don't bend much. And she didn't really have any of that. Her knees were slightly valgus or knock-kneed, which is really common sometimes when you have front of the knee wearing down. But overall, her knee was quite good on scan, and I explained this to her and said that she didn't have osteoarthritis everywhere. And in my opinion, I didn't feel she needed a total knee replacement, because if I can, I'll try and keep the patient away from surgery, and I certainly don't want to remove all the surfaces of her knee when 60+% or 70% of her knee cartilage is excellent. So between her tibia bone and her femur bone, there's no issue. So for me, that's not a total knee replacement. Potentially, she could have what's called a partial knee replacement of the patellofemoral joint, which is where I normally use robotic tools to help me just burr away the worn top 2 millimeters of the worn bone at the end of the femur, and also the top sort of 8 millimeters of the back of the patella bone, the kneecap bone. And we normally replace those worn out surfaces with some metal and plastic pieces that fit the same. But even that's the biggest thing she would need. And what we wanted to do first is get her to understand her problem and figure out whether we could get her feeling better without taking her to perform joint replacement surgery. And so we did some blood tests as well. I asked a lot about her lifestyle, and it turns out she doesn't go to the gym or do any strength training. So for those of you that watch my videos, you'll know that I am insistent that you get to the gym at least once a week for 1 hour if you can. Ideally 1 hour, 10 minutes or 20 minutes would be great. You get on all the machines in the gym where you move your legs in different directions. So that would be like the hip abduction machine, the hip adduction machine, the leg press, the calf raise, the leg extension, the hamstring curl, and also to do something called deadlifts, which are great. So that would be my combo. I would like those exercises done normally like 6 reps, 6 to 8 reps, maybe 3 or 4 sets, 4 sets if you've got time. I've started doing 4 sets now. I used to do 3. And if you can do that once a week and just slowly increase the weights, every few weeks when you feel comfortable, just a little bit, just to keep the resistance up, your muscles, doesn't matter what age you are, how medically or physically fit you are or not, your muscles are going to grow and get bigger, especially if you increase your protein intake. Maybe consider taking some supplements like creatine, which can help your muscles grow. Make sure your vitamin D is appropriate, and again, take supplementation if you need. Make sure your magnesium's good. All of these things are really going to help your body grow and your legs grow. And if that's the case, the pressure in your joints, especially your knees and hips, is going to reduce. And pain normally because of osteoarthritis isn't because your arthritis has worn away directly. Pain in your joints because of osteoarthritis isn't because the cartilage is worn away directly, because cartilage is aneural. It doesn't really have nerve fibers or endings, so the cartilage is damaged. It doesn't normally hurt you directly. It hurts you because the damaged cartilage or the loose bits moving around that aren't smooth trigger nerve endings in the inner lining of your knee joint called the synovium, and it triggers them to release chemicals and liquid and fluid that is really painful, that has kind of toxins in it that cause or set off the nerve fibers in your knee that sense pain. That's called nociceptors. So when you get that, you feel pain, it's because of the inflammation. If the inflammation goes, even though you still have some worn away cartilage, it doesn't hurt you anymore. So the problem with having less cartilage is the force going through the bone is more, and the bone does have nerve endings in it, and that pressure in the bone can hurt you and again cause inflammation. So if you get the pressure down, either by losing weight if you're overweight, or more importantly, I would say by increasing muscle in your leg, getting bigger muscles, because we all have the same number of muscles in our body in general, whether we're super muscly like Arnold Schwarzenegger used to be, or not very muscly. We have the same number of muscles. It's just that in bodybuilders, they're really big. So what you want to do is become a bit like a bodybuilder, which sounds ridiculous if you've never been to the gym, but you can get stronger. You just need to go once a week, 3 or 4 sets, 6 to 8 reps minimum in terms of one session, and you will get bigger as the months go on. If you can go twice or even 3 times, that's better. I actually think twice is more than enough to do your legs. If you want to go to the gym for other reasons, that's fine. You could do a little bit of cardio or jogging. Get on the rowing machine, do cycling, you could do some upper body, you could do some classes, you could definitely do other types of exercise that are good for you, like Pilates or yoga or swimming. Exercise is important in that it's a bit like having a balanced diet. So you might need vegetable and fruit and a bit of fat. They're all good for you. You're just not going to get anywhere only having a protein diet or only having vegetables. So likewise with exercise, if you're doing it, that's great, but you only bodybuild 5 times a week, it's just no good. You want to have a balanced week. For joint pain though, resistance training in the gym with machines is the most important thing you can do. And though you can do strength training at home with body weight or kettlebells, it's just not enough for the need to reduce pressure in your knee, in my opinion. Now, I'm not a physiotherapist, I'm just a humble orthopedic consultant surgeon, but for decades, I've worked alongside hundreds of physiotherapists and been very fortunate to learn from some of the best. Also work alongside some of the best strength and conditioning coaches in the country, and also sports scientists and sports and medicine and sports and exercise doctors. And I read a lot of research every week. So in my opinion now, and it's a fairly well-informed opinion, the best way to grow muscle, which is what you need to reduce load in the joint, is doing 6 to 8 reps, 3 to 4 sets. And though the more you work out to a degree, the better, I'm very realistic. I just want you getting into good habits. If you can do that once a week with your busy family life, busy work life, that's fine. It's better than going hard for 3 or 4 times a week and then not being able to do it ever again. So we just want to embed good habits, and that's all I do. I normally do legs once a week. I'd like to do it more, but I just can't because I'm busy with all my work and all my family, and I'm trying to build a health tech app to help patients get an early diagnosis for their knee or hip pain and to get the right advice on treatment. So I'll let you know more about that later. So with this patient, we got her in the gym. She didn't want to go to the gym because she does yoga all the time. We got her going at least once a week. She now goes twice a week. She loves it so much. She's stronger, she's fitter. Her diet was always quite good actually, and her stress levels were good because she's a yoga teacher. But we did realise with some blood tests her vitamin D levels were low, so that got sorted with supplementation. And also she started taking magnesium supplements, which really helped her. And some collagen orally, which I'm not sure if it's super helpful, but it seems to have helped her. She has avoided total knee replacement. She doesn't even need partial knee replacement, which I would perform on her if she needs it. And she doesn't even need an injection therapy. If she does start to get in trouble though, we'd think about injection therapy. And I deliver that ultrasound guided, so it's really accurate and you can see where the medication is going. And in terms of injectables, I'd consider something like platelet-rich plasma, which I've done lots of videos on, which is your own blood, and we centrifuge it once or twice to collect the proteins and what are called cytokines and growth factors that help you mend, and inject them back to the knee. And often the knee can be stimulated to try and protect itself and stop breaking down further. You can also have something called hyaluronic acid, which actually doesn't have very good medical evidence behind it anymore, but I've used it in thousands of patients over the last decade, mainly because I did have it on the NHS until recently, and patients absolutely loved it. There's no harm to it, in my opinion. It's a really good lubricant and very slight cushioning effect it has. So that's really good. And the other thing we could inject if you have quite bad arthritis, which she does a little bit, but maybe not severe enough, is something called Arthrosamid. And I've also made a video on Arthrosamid, which is a one-off thick viscous gel it gets injected into your knee. And we used to think it acts as a cushion. It doesn't really. What it actually does is it kind of binds to the synovial lining in your knee. So that's the lining that produces the inflammatory chemicals, and it just shuts it down and stops it from doing that. So that's a really effective treatment that we've noticed can help patients for many years, up to about 5 years at the moment, in about 80% of patients who have it. And it seems to work better on people who are a bit younger, i.e. less than 70 or less than 75. It seems to be a little bit more successful, but it can still work in older patients. And it seems to work a little bit better if you have isolated arthritis behind your kneecap. We're not sure why, but that's what the data shows. So injection therapy would be next, but she doesn't need it. So that's the thing. If you think you've got osteoarthritis, just make sure that you have had your scans and x-rays explained to you by your doctor so they can show you all the areas of your knee, and ideally they can show that the cartilage is severely worn away and it's affecting all parts of the knee. If it's only affecting one area of the knee, either the inner part of the knee, which is called the medial aspect, the outer part of the knee, which is called the lateral aspect, or the front part of the knee, which is called the patellofemoral joint, then it's absolutely reasonable to consider asking them, if you needed surgery, could you have a partial knee replacement, where we replace one of those three components of the knee. So there's three areas of the knee: the medial or inner aspect, the lateral outer aspect, or the front or patellofemoral joint. So each of those three zones can be replaced with a smaller implant if needed. Also ask them about injection therapy and if that can help you. I think all injections are pretty good. Corticosteroid as well, which is really unpopular. I'm not sure why. It has a place, I feel. It's a great anti-inflammatory, good painkiller, and gets you back active quicker. Have a place. They're probably all about 80% successful. So if you're going to have a knee injection, and again, I've done a video on all the knee injections and which ones you might need each one, I would say you've got a 1 or 2 out of 5 chance that the injection may be a bit underwhelming, but a 3 or 4 out of 5 chance that it's going to really help you for many, many months. And in the case of Arthrosamid, for up to 5 years at the moment. So they're worth trying, but they do much better if you also are treated holistically. So lifestyle and longevity medicine hat on as an orthopedic surgeon that fuses these branches of medicine together to treat you holistically. Your injections and even your surgery will do better if you can reduce your weight somehow, so you're not overweight or you're carrying less fat tissue in your body. That's not just because fatty tissue and being heavy puts more load on your joints, it's also because there's a lot of inflammatory chemicals that are released more so when you're carrying more fat. So we know fat is really bad for you in many, many ways. Also do better if you grow your muscle in terms of going to the gym and getting bigger muscles. That's going to reduce the load going through your joints, keep your joints stable, cushion you and protect you from injuries, and keep you upright, mobile and active as you get older. So having strong leg muscles is going to directly impact your longevity and how independent you're going to remain as you become an older person. And that's incredibly important. As a trauma surgeon in the NHS, I'm constantly seeing patients who fall and break their hip after a certain age, normally over about the age of 75 or 80. And if you're really frail at that stage, your chance of dying within a year from after one of those injuries, though we fix these injuries fairly successfully, surgery to either fix the hip or to replace the hip, is about 50%, because patients normally, because they're so frail, they tend to fall, break the hip. It's almost like a sign of frailty. And it's just a terrible thing if you know anyone that's had a hip fracture and been to hospital, or if you even had to have it and you've been recovering from it. It's really tough, and people are not always the same again. So we want to prevent this from happening. You want to stay strong, you want to get in that gym. It doesn't matter what your age is or what your size or shape is, just get there. No one else cares. And again, I've made a video on what you do in the gym. If you're not sure about what to do, you're a bit nervous and you don't know how anything works, I've got a video for beginners that you can watch on the YouTube channel. So in terms of scans and x-rays, they just show structure. They are not a diagnosis and they don't really show pain. So it's important you know that an MRI scan just shows bone, cartilage, tendon, ligament, muscle, meniscus, but it doesn't show pain. It sometimes can show pain indirectly with some inflammation maybe, and maybe a bit of swelling in the bone marrow, but you are not your scan, and it's important you understand that, and it's important your doctor or physio understands that. I've seen lots of patients who have terrible scans and x-rays and they feel pretty good, and vice versa, where they feel terrible and they've got loads of pain and actually their scans and x-rays are fine. So there are other factors at play that make you feel pain, like inflammation, poor metabolism, increased weight, poor diet that triggers inflammation, and that inflammation could be within your joints or even to do with your gut microbiome, mild allergies that have never been put picked up, vitamin or mineral deficiencies that have never been picked up, low mood, depression, loneliness, all of these things can make you feel pain more. Lack of sleep in particular, you need to be trying to get at least 7 hours sleep a night if you can, and that's really difficult for me at the moment because I've got a 6-month-old and a 3-year-old. But you know, you've got to do what you got to do and try your best. I now watch much less TV and go to bed really, really early just to try and get some sleep if I can. So we've all got to work within what we've got, but all these things can help reduce our pain. But strength is the most important thing you can do, better than anything, better than any surgery or injection. But what can you do if you've got too much pain? Of course, you can't just get in the gym and do endless leg presses. I understand that. So that's why injection therapy can be good to help pain, and that's why some corticosteroid therapy, though it's sort of frowned upon because it can also damage the cartilage, some studies have shown. I think if you've got quite bad arthritis in the knee, it doesn't really matter that much. You can have a steroid injection, it will reduce the pain and swelling in the knee. You can get to the gym, it might save you surgery. So think about that. Other injections like hyaluronic acid, which I mentioned, Arthrosamid and high-dose PRP, I've made a video on that if you want to understand what that means. They can all be really helpful at reducing pain and inflammation in the knee so you can get to the gym and do your exercises. Of course, if you're really struggling, sometimes you just have to have a total knee replacement. I replaced my neighbour's knee and it went really well in the end, but you know, that was nerve-wracking because, you know, if it didn't, obviously I have to see my neighbour in the garden all the time. And knee replacement surgery can be really, it does have a relatively high rate of unhappiness. By that, 15 to 20% of patients who have a total knee replacement are really happy with it. But if you compare that to hip replacement, where I would say 97% or 98% of patients are super happy with it, it's not quite as good in terms of outcome as a hip replacement. And that's because knee replacement surgery, I would say, is more complicated. I do both, so I can say that. The knee is a more complex joint. To replace it, you need to really be careful about how much bone you remove, what angles you cut the bone surfaces away, and how you put the implants in. So you want to make the knee very balanced, so it's nice and even throughout the range of motion, so it's not too tight or too loose in different areas. You want to make sure the kneecap bone isn't unstable. You want to make sure you're not damaging any of the ligaments in the knee that you were leaving behind from your surgery. And overall, the knee is just very sensitive compared to the hip. It's got a lot less. But what can you do if you've got too much pain? I mean, it's easy for me to say go to the gym, but it's really hard for you to go if you're in agony and the knee is stiff or it's unstable. So the first thing is to consider injection therapy, because the injection therapy might help you get to the gym. If the injections help, whichever one of the ones that I've explained is administered, you may get less pain in the knee, less swelling, less stiffness, and then you can start that slow journey. And slow is totally fine, just to get the knee moving again, get it kind of bending and straightening. Maybe try a little bit of exercise gently on a static bicycle, for instance, a little bit of very light resistance training. But if it's still really difficult, then it may be that you need to have surgery. And as I said, you can have partial knee replacement surgery if one of the 3 areas of the knee is very worn away and the other 2 are fine. But if 2 of the areas are worn away, or definitely 3, then you may want to have a total knee replacement. And total knee replacement surgery is really successful in about 80% of patients, but it is something that sometimes does take a long time for you to recover from, normally about 3 to 6 months, because the knee after the surgery can be quite swollen, the leg can get quite swollen as well. It can be difficult to bend the leg, it can be very painful after surgery. Normally the surgery itself isn't painful, but normally from the next day onwards, you can start to get discomfort. So painkillers are really important after this sort of surgery, where they're not as important normally after hip replacement surgery. And walking normally fully weight bearing on your leg is allowed, though I tend to give patients crutches for a few weeks for comfort, but we are keen that you put weight on the leg. It's also really important you ice the knee a lot. You can either buy special things that wrap around your knee with Velcro straps, that cold water from a pump kind of shoots water around the knee, and that's the sort of therapy that you can purchase or rent from the hospital if you have your surgery in a private hospital. Otherwise you can purchase them. Otherwise just old-fashioned ice packs or frozen peas from the freezer. Put on a little kitchen towel just to make sure that you don't get an ice burn. That's totally fine. Normally after knee surgery or knee replacement surgery, for another 10 minutes you should practice moving the knee, trying to get it fully straight and bend it as much as you can, and really need to push this and be as tough as you can be. And for another 10 minutes, you want to practice walking with your crutches, putting your foot on the floor and trying to put weight on, sharing with the crutches. And then you've got 30 minutes and then you can rest. And then I'd start again, next hour, again, 10 minutes moving the knee, 10 minutes walking, 30 minutes rest. So for the first 2 weeks, if you do that, your recovery will be much faster. And I'm going to make a video actually on recovering after knee replacement surgery, because I think it's a really difficult thing for patients to do, and they often don't always have all the research or the right advice to kind of help them avoid pitfalls and things. So, don't feel like I'm saying you can't have a knee replacement. I do them most weeks, but I do feel strongly that a lot of patients may be slightly over-operated on, and other patients maybe are also kept away from surgery when they probably should have it. So it's really important you see someone who can kind of offer all the treatments, and that's what I try and do with my OrthoLongevity approach. We can offer all treatments from, advice on nutrition and sleep right up to total knee replacement and everything in between. And that's because, I've learned from so many different health professionals now, not just surgeons, but also medical doctors, lifestyle medicine doctors, physios, osteopaths, strength coaches, nutritionists, and this is something that I'm really passionate about. So hopefully this video has really helped you, especially if you've got really severe knee osteoarthritis and are awaiting a knee replacement or wondering if you need one. Do put comments in the comment section, because I actually read all of them and answer all of them at the moment. And let me know if there's any other videos that you want me to make about this topic or anything similar. Thanks so much for